Okay, third topic, into the final stretch here. We're going to talk about acute stress disorder and post-stress disorder, recognizing when we've tipped over into distress, and then having a bit of an understanding about caring for ourselves and also getting professional help if we need it. So critical stress is a term that I'm using loosely for basically when it's just too much. And critical stress is not a really properly clinically defined term, but it's a useful sort of catch-all of just too much stress. So it encompasses feeling bad, but it also encompasses the actual defined terms of acute stress disorder and post-traumatic stress disorder. So let's talk about stress disorders and what are they? Well, there's a book called The Diagnostic and Statistical Manual of Mental Disorders, which has been around since I think roughly the Second World War, maybe the 30s or 40s, somewhere around there. It's in its fifth version right now. Well, it's actually more than the fifth version because it had text revisions and stuff like that. But the most recent edition came out in 2013. It's created and published by the American Psychiatric Association, the same APA that you have to do all your essays in. So you can thank them. And it lists all the different things that we consider to be mental disorders. So if someone says, oh, they're paranoid, we say that sort of casually, but there actually is a definition for paranoia. If we say someone is schizophrenic, there actually is a definition for schizophrenia that the entire community, professional community uses. And those definitions come out of the DSM. So the DSM, it isn't the only book like this. There's another set of criteria that's used more commonly in Europe, and here DSM tends to be used more in North America. Here in Australia, we tend to use a little bit of a combination of the two. We're not quite as wedded to the DSM as North America is, for example, because it's the American Psychiatric Association. But it is, regardless of where you are in the world, a very influential and very powerful book that affects your thinking about these mental health disorders. If you're taking a counseling or psychology course anywhere in the world, you're going to be studying the DSM. It's so foundational a text. It used to be that stress disorders were subsumed in the chapter basically on anxiety, but now they get their own specific category. And acute stress disorder, post-traumatic stress disorder are no longer considered a type of anxiety. They're considered conditions in their own right. And as I said, the definitions for acute stress disorder and post-traumatic stress disorder come out of the DSM. So where did we get this whole idea of post-traumatic stress? It's a very common term right now, but when I was a kid, there was no such thing as post-traumatic stress, at least not formally. The actual definition of post-traumatic stress disorder arose, not surprisingly, from the military. And when a whole bunch of Americans came back from the Vietnam War, which was an extremely challenging war for the country and for the people who were involved in it specifically as individuals, they started having very powerful reactions to their experiences in the war, and they went to get help. And everybody said, well, there's no formal recognition for what you're going through. So I don't really have any way to study it. I don't have a way to label it. I can't really bill you for it because it's not recognized as a disorder. And there was that last one, the fact that you couldn't get billed insurance companies to support it because insurance companies said, well, if there's no diagnosis for it, we're not going to pay people for getting helped because it doesn't technically officially exist. So it was really from a lobby from the Vietnam veterans to government and to the American Psychological Association that said, we think that this actually deserves to be labeled as its own thing. And in around 1980, they actually agreed with them. And in 1980, I think it was DSM-3 that was in 1980, I'm not sure. Post-traumatic stress disorder was formally recognized for the first time. And that's when people said, okay, now we got a definition. Now we can start to measure it. Now we can start to research it. Now we can start to look for what therapy is best for it and all that sort of stuff. So in 1980, really, this started to take off. But of course, it existed far before that. Humans get post-traumatic stress disorder. Probably we've gotten it for as long as there have been humans around. We know we have case records going back to the American Civil War in the mid-1800s that show us that those people had what they used to call the 1,000-yard stare, or sometimes they called it shell-shocked. A lot of people came back from the First World War, and they were described as being shell-shocked. And we now know that that was post-traumatic stress disorder. And those people were usually just like put in homes and ignored. which is tragic because there's a lot of really good treatment for PTSD now. It can occur at any age. Kids get post-traumatic stress disorder. There's a slightly different set of definitions for kids and how they get it. But it still is post-traumatic stress disorder. They just manifest it differently. Women are twice as likely as men to get PTSD, and people who are exposed to traumatic situations get PTSD in like a dose-response relationship. So the more stress you have, the more PTSD you get. So that's how we helped establish that it's actually caused by these terrible situations and not by some other causative factor. So I've talked a little bit about acute stress disorder, which I keep mispronouncing, and post-traumatic stress disorder, and the fact that they're a little bit different. Let's take a look at what the actual definitions are for those two conditions, because these are the main definitions that people get for critical stress impairment. So acute stress disorder, it lasts for about a month or less after the precipitating traumatic event. So if you're still stressed about something 2 months later, it doesn't fall under acute stress disorder anymore because it's been going on for too long. It has to be within 4 weeks of the initial event. However, it can persist for months or years, and in that case, we call it post-traumatic stress. So after a month, we click over from acute stress to post-traumatic stress. 1 month is kind of the transition line. The DSM says that about half of the patients who experience PTSD also experienced acute stress disorder, which means that half the people didn't. So it's possible for you to be okay for a month, or 2 or 3, and then start to feel the effects of that initial precipitating traumatic event and go directly from, basically okay-ish to post-traumatic stress disorder without having experienced a very strong reaction, stressful reaction within the first month. So you don't necessarily have to have acute stress disorder to develop post-traumatic stress disorder. You can unfortunately just jump right into post-traumatic stress disorder if your symptoms initiate a month after the precipitating incident. Okay. Another important difference is that in PTSD, they really emphasize the presence of dissociative symptoms. So you tend not to dissociate as much when you're experiencing acute stress disorder, but in post-traumatic stress disorder, there tends to be much more dissociation. And we talked a little bit about what dissociation is, but here's a list: feeling numb, unable to remember traumatic events, feeling spaced out, feeling unable to think, poor memory, just kind of, for those of us who are old enough to remember that you could pick up a landline and listen to a dial tone, that experience of just sort of personally being stuck on dial tone, just kind of sitting there going, and you can't really get yourself out of the chair. You can't get yourself to think critically. You can't get yourself to actually be effective in any way. You're just stuck in dissociation. That's much more characteristic of post-traumatic stress as opposed to acute stress disorder. However, if there is a lot of dissociation in acute stress disorder, or before post-traumatic stress disorder kicks in for those who didn't experience acute stress disorder, then that tends to be a lot more predictive of the fact that you're going to get PTSD. So the dissociation tends to be a protective thing. We go into the bubble, but you can't stay there forever, or else you starve and you're not functional. So when you come out of that dissociative state, you are now forced to start dealing with all the things that you've been ignoring. And that becomes very traumatic. So again, dissociation is a very effective short-term strategy, but a very ineffective long-term strategy. Okay, so what's acute distress disorder? If we were to talk about what that actually is, how would somebody define you as having ASD? If you came in and started saying, oh, these terrible things are happening to me, I would either on paper or in my mind as a counselor have this checklist that I would sort of be going through, and I'd ask open-ended questions and see if you spontaneously offer any of these things. So first of all, did something bad happen? Was there some sort of initial precipitating event, either a singular event or a series of cumulative events? And basically, if you come in and you say, yeah, I'm a paramedic or a police officer or a soldier or an emergency nurse or a dispatcher or a doctor or an ICU nurse or corrections, all of those things right away, we've satisfied criteria A. And then there were some bad emotional, I'm speaking colloquially obviously, bad emotional reactions to this bad thing that happened. So we get intrusions into our awareness, flashbacks and nightmares. We get negative moods, we're sour or surly. We lose our positive emotions. We dissociate, we space out, and people go, hey, are you listening to me? What? We have avoidance symptoms where we focus overly on things that are distracting for us. So we just, get into hobbies or whatever in sort of an obsessive way. And we have a lot of arousal symptoms. So we get angry or we're startled easily, this heightened startle reflex. Wow, that's very characteristic of PTSD. Or we're just confused and kind of stuck like this. That's very characteristic of PTSD. As we say, it occurs, or ASD, it occurs 3 days to 1 month after the incident, and it impairs our normal function. You can have these other things and still just function just fine. They're just kind of bothering us. But in order for it to be ASD, you have to get to the point where this is actually interfering with your life. You're not going to work. You're calling in sick. You're canceling social engagements. You're not participating in activities that you would normally participate in. You're so depressed that you don't get out of bed, you don't wash for a few days. That's significant impairment in your normal function. And as sort of a catch-all thing, it's not due to something else. You don't have, chronic depression. You aren't malnourished. You didn't just get a diagnosis of cancer that you're going to die and you're grieving. It's actually because of, in criteria A, something bad that happened. That's acute stress disorder. That's how we diagnose this. That's how we look for it. If I'm submitting a claim saying that somebody should be get compensation from their insurance provider because of acute stress disorder, the insurance provider is going to say, prove to me that all those things are there. Did they actually talk about that? Is this what's going on, or is it something else? And I go through this process to say, yeah, this is actually what's going on. In contrast, PTSD is a little bit different. It's kind of like the bigger, uglier cousin of ASD. So again, something bad happened, similar to acute stress disorder. Won't repeat all that stuff. There are also some intrusion symptoms. There are some avoidance symptoms, negative alterations in cognitions, which is thinking, and mood, which is our sort of emotional tone. There are alterations in our arousal and reactivity, which is the heightened startle reflex, or depression and anhedonia and all that sort of stuff. It lasts for more than a month, not a month after the precipitating event, but these symptoms, whenever they started, have been persistent for more than a month. It is interfering with our ability to go through our daily lives, and it also isn't due to anything else. So very similar in a lot of ways to acute stress disorder, but some subtle differences. The biggest one being the dissociation and the fact that it lasts for more than a month. For the folks taking Para 104 at ACU, I've got a handout up on the learning site on Flow. It's not Flow, it's Leo. Flow flows from when I taught at Flinders. Leo. And it gives more detail about these disorders in some depth. And I want you to read that. I want you to be familiar with these symptoms. So ignore the fact that it says Flow. If you're going to ACU, it should say Leo. And sorry about all the TLAs, 3-letter acronyms. Okay. Something really important for us to remember is that PTSD is a normal response to an abnormal event. We are just, as Tim Minchin says, apes that wear shoes. And if you take human apes and throw them into these incredibly bizarre and abnormal situations with decapitated people and decomposing bodies and all the horrible stuff that we see as paramedics, then it is normal for us to get post-traumatic stress disorder. Eventually, people get overwhelmed. It's kind of like if you have an attitude that PTSD is just weak people, that people who can't hack it, that's analogous to saying, this guy came into the gym on his first day and he tried to bench 500 pounds and he dropped it on his chest and broke his sternum. He's weak. No, he's not. That's what happens. Our muscles can only lift so much weight. Our emotions can only bear so much tragedy before they start to fail. And PTSD is a normal reaction to overwhelming stressors. Oops. There goes my alarm again. Sorry. I have my phone and everything turned off, but that's my alarm. Okay, anyway, so nobody who sees really bad trauma is untouched by it. Even if you're not consciously aware of it, it does, I would argue, affect you. And that's how we get these cumulative effects of many small stressors. It's normal for you to feel a sense of being threatened and a sense of your family being threatened. When I had PTSD, I was living an hour north of Toronto, and I used to have nightmares about cops coming up from Toronto trying to kill my family. My family was threatened, and it was from the official services in Toronto. That's why it was arising in my mind. Sadness, grief, anger, they're all normal things, and all of us are different. Acknowledging our feelings, so talking about this mindfulness, awareness, and acceptance actually helps us to recover. And that's why we found that mindfulness-based therapies are so helpful, because we've taken this thing which is so horrible that we've put it off sort of in a separate encapsulated area in our mind, and gradually what we need to do is reintegrate it into our general awareness. That's the work of recovery. Accepting help is healthy, even though in our culture it's often something that's very difficult for us to do. But we also have to understand that all of us deal with this in different ways. There's a spectrum of extroversion to introversion, and people want and require and need and are helped by others in a variety of different ways. And it's important to be respectful about that. How do we recognize if we have critical stress? This is easy. It's a one slide sort of discussion. I've made this list, and if you're in Para 104, then take this from the PowerPoint. If you're watching it on YouTube and you're not in the unit, that's fine. Nice you're here. Take a screenshot of this, print it up, and post it on your fridge if you're working as a paramedic or a paramedic student, and every so often look at it, or post it beside your toilet. And when you're sitting there with nothing else to do, just read over it and say, how much of this is going on in my life right now? And if you can highlight a lot of these as stuff that's going on with you, then you have tipped over into critical stress. What do we do if we've tipped over into critical stress? Well, we take care of ourselves. How do we do that? First of all, go home. If you're at work, go home. You're no good to anybody when you've been injured by stress. You need to start the healing process. And if you don't have a workplace that recognizes acute stress injuries as actual injuries, then just tell them you're sick. Tell them you threw up or whatever. Just lie and go home, because you need to protect yourself. And the fault is theirs for not recognizing stress as an injury, as opposed to you for having to, game the system in order to be able to protect yourself properly. This is where we get into moral distress again. You need to heal from this the same way you would from a physical injury. It can take hours, days, weeks. It could take years. You don't know. It depends really on just how bad it hit you. Talk to someone about your feelings. There's lots of emotions that can possibly come up. It's useful to talk about it, but only, this is important, only if you want to, and only as much as you want to. You may find the overly therapeutic friend who just wants to bleed you dry of all your emotions at the time and thinking that it's very helpful. Don't let them. Protect your space, protect your boundaries. Say, you know what? I've had enough. I don't want to talk anymore. Thanks for listening, but I need to stop now. If they say, no, you need to keep going, say, you know what? I actually watched a lecture on this and I don't need to keep going, and maybe you should look at it, and give them the link. And if you got sent here by a friend saying you need to take a look at this, then maybe you need to know that you should not force people to talk about the feelings. There's no obligation for people to have to. It's up to the person who's having the emotions to determine how much of a release is healthy for them. And that's entirely unique and individual. I really want to stress that. So don't force yourself or be forced or let someone else force you to talk about things or to experience things that you're not ready to yet. It's up to you to figure out how fast you jump into that hot bath. This is your call solely, okay? And also realize that the bad things that happen didn't happen because of you. If you're coming there as a paramedic, you're there to help. You didn't cause it to happen. And I know that that's sort of an argument between the scientist and Amy Amy usually wins that one, but it can be helpful just to keep in mind that you didn't do this. You had nothing but the best intentions. You went there to help. Easier said than done. I know, I've been there. It's easier said than done, but it does help to say it. As a general guideline, we want to burn off all the adrenaline and cortisol that bodies have just produced inside us and dumped into our bloodstream, and stop making more. So some general strategies, and you've probably heard these before, but it's a good review. Exercise if you can. Even though you will already be feeling exhausted, go and do some gentle exercise. Again, walking is the best thing. Eat good food. We're tempted to eat crap. We reach for potato chips and candy and Coca-Cola. Don't do it. Eat only good food. You need some internal discipline because your body has just produced a whole bunch of chemicals and you need to replenish those supplies. The serotonin and the oxytocin and the other feel-good chemicals that we have in our mind that we use as a part of our parasympathetic rest, digest, relax, and recover system are also made from the foundational chemicals as the adrenaline and the cortisol. And if our body has to choose, it'll always choose to produce the adrenaline and the cortisol because those are the things that keeps us alive. So if we are forced to create adrenaline and cortisol, it's going to deplete the resources that we have for the other hormones that allow us to relax, rest, and recover. So we need to fuel ourselves properly with good food so that we can start to rebuild our stores. Avoid caffeine. You're stressed enough. You don't need any more caffeine because caffeine stimulates our sympathetic nervous system, and you can only have one or the other, sympathetic or parasympathetic. I've got a lecture on that too, the autonomic nervous system, if you want to look for it. But the autonomic nervous system consists of the sympathetic and the parasympathetic. And if your sympathetic is on, your parasympathetic is off. And your sympathetic will already be really high because you're filled with adrenaline and cortisol. So don't give it caffeine and push it up even more. You want to try and get more into relaxation. So avoid the caffeine, avoid the cigarettes. Try to get some sleep, even if you're having a lot of trouble. If you're having a lot of trouble in the short term, go to your doctor and ask them for a short-term benzodiazepine. They'll give you like 5 or so that you can sleep over the next few nights and allow your body to recuperate. Temazepam is a good one. There's a bunch your doctor will be able to prescribe, but explain that you're a paramedic and this is what you've seen and you're having flashbacks and it's impossible for you to sleep and you need to recover. And most family physicians will be fine with that. Don't be surprised if they try to refer you on to a psychologist. Maybe that's a good idea. All right. Avoid alcohol. Alcohol allows us to get to sleep more quickly, but it disrupts our sleep and it makes it difficult for us to get into REM. So you fall asleep more quickly, but it's a crappy sleep. So although it's a bit of a crutch to actually get you asleep, it's a bad one to use because it doesn't allow for that recovery, which is ultimately what we want from sleep. Do some relaxation exercises, deep breathing, yoga, stretching, whatever it is that you do to relax. If you're not sure how to relax, then YouTube relaxation exercises and do some of those. One of the best ones is listening to some soft music, putting your hand on just above your diaphragm and breathing into your hand and breathing out and feeling your whole body relax, becoming aware of your body. So relaxation exercises help. Try to keep on cleaning. Don't let the dirty dishes build up in the sink. Don't become a stinky body odor factory. Keep yourself clean, keep your surroundings clean, keep up with the minimum that you need to do in order to feel like a civil human being. That doesn't mean go out and work diligently on your PhD or, this excessive sort of stuff. It just means keep the dirty dishes out of the sink, keep the dirty underwear off the floor, do your laundry, wash yourself, keep the place tidy. Spend some time with your family and friends. If you like your family and friends. If you don't, well, get new friends. You can't get new family. But get new friends and avoid your family if they're toxic to you, which for many people they are. So find people that you actually really like and try to spend some time with them. I really strongly urge people who are paramedics to find a really good friend who's a paramedic or a cop or a nurse or something and sit down and consciously say to them, I'm looking for a buddy that I can call at 3 o'clock in the morning when I know things are too bad. I'm looking for someone that I can talk with and share with, and I'm willing to be that for somebody else. Now, as your students going through the university program, it's a great time to find friends like that because you're about to go out into clinical practice and you might come home and just be really messed up and need someone to talk to. And having another student that you can talk to is a fantastic thing to do. I'll also talk about some other resources for students. Don't be afraid to hide. This is okay. Make yourself a pillow fort or a blanket fort, or find yourself a cardboard box that you fit in, figuratively speaking, metaphorically, and just lay low. Turn off your phone, put a message on it saying, I'm unavailable for the next few days. Send me an email if it's urgent, and then just, don't check your email. Stay off of Facebook. Just lay low and try to stay off social media. Try not to be overburdened with your responsibilities. Cut it down to the minimum. And if you're a paramedic, most of your friends will understand that there are times when they're available that you're just not available because you work night shifts, and sometimes you're on night shift, and it should be pretty standard for you to just turn off your phone so that you can sleep through the day. So if your phone's been off for a few days, most of your friends will understand. If you're on Facebook or social media, say, dropping off for 3 days, I'll be back, I'm fine, just need a bit of a rest to recover from shifts or whatever, and take some time for yourself. You are worth taking that time. You need to recover. There may be some memorials or rituals or use of symbols. Perhaps you're a person of faith and you can find some consolation through prayer or meditation or whatever is useful for you. Maybe you're not in a religious community, but there are just some things that you can do that would be helpful for you. When I had really bad calls, I feel the emotions coming up now, but when I had really bad calls and things really affected me, I was practicing Zen Buddhism at the time, and I used to go home and I used to just light a little stick of incense for those people and sit in a quiet room and let the incense burn and let myself be present with those people. And that incense was, to me, an offering. Did it do anything objectively? Probably not for anybody else except me. And that's okay. So whatever works for you, and people often have a real sensitivity to goofiness and stupid stuff here of, what am I going to do? Sit in a corner and shanti shanti om? Is that really what you want me to do? No, I want you to do what works for you. You know what? Maybe just going out and looking at the clouds. Maybe that works for you. Maybe you draw a picture. Maybe you write down what happened and then you go in your backyard and you burn it. And that is what works for you. But whatever you find is effective and functional, do that. Talk to your friends, talk to your support groups, talk to your religious community, anybody who's a good connection for you. If you can do these things with other people, if there's some sense of ritual that you can do that involves other people as well, that tends to, I don't know why, but just as apes with shoes, this works, that tends to amplify the sense of power and effectiveness that we get from it. Maybe it's placebo, who cares? As long as it makes you feel better, go for it. And it doesn't hurt anybody else. Talk with your family if you have one. Talk with your extended friends. Have a plan for when you're emotionally hurt, so that you can come home and your husband can say, hey, honey, how was today at work? And you say, you know what? We're just going to go code yellow here. It was a crappy day. And the husband says, no problem. I got the kids. You go relax. Of course, we can't abuse that because that's something that our partner is offering us. So only do it when it's valid and, don't abuse it. But if you can create a system like that with your partner, that is a really, really effective thing to do. And you know what? They'll recognize it. You'll walk in the door and they'll go, oh, you okay? What? How can you tell right away that something's wrong? They can just pick it up if they're sensitive. So have a plan for how this works and what you're going to do about it. It's really important that you can just turn on, this code yellow, or code red. A code red is I'm just going to my room and I'm closing the door and don't bug me. Whatever works for you, have that work. Now, in a community of our peers, we're going to see this start happening with other people, and we're going to want to help those other people. And we got to be careful because we can do things that are inappropriate. So we can just be there to informally debrief with other people after critical situations. You will come to know your partner when you're working as a paramedic extremely, extremely well. If you have a long-term partner, these are long-term, intimate relationships. If you're with a partner for 10 years and you add up the hours, you will probably spend more hours awake with your partner at work than you do with your life partner, your intimate partner at home, wife or spouse or whatever it is. As an older paramedic, be careful of the new and inexperienced staff. When you see some rookie little student doing this at a call, go over and talk to them, take some time and help them out. For the students in the unit, obviously, this is not the time in your career when you're going to do that. But as a senior student, if you know junior students and you hear some of them talking about this, it's a time to intervene and say something like, "Ooh, that sounds like a bad call," and see if you can talk with them a little bit. Talk to those people. Tell them, hey, it seems like you're really being affected by that. Don't come up and say, I'm concerned about you, because that just sounds very artificial. But just let them know that you care. Tell them that. Don't say, hey, are you okay? Say things like, wow, that sounds pretty bad, or that sounds pretty intense. And then just leave it open. People don't like empty space. They tend to fill it in. So if you can kind of lightly color that empty space with, oh, that sounds like a really bad call, they're going to want to fill it in. And they might say, yeah, it wasn't too bad. It was all right. I'm okay. Respect that. You can then say something like, if you want, if you know them and there's some rapport, say, are you sure you don't seem too okay? If they go, look, I'm fine. It's like, hey, no problem. I don't want to press. If you ever want to talk, though, I'm happy to talk with you. And then let it go, because it's up to them to titrate this off-gassing, okay? Realize that some people have PTSD and they're not aware of it. I was not. I think it took me about a month or so to actually figure out, hey, this is post-traumatic stress. It was an immense relief to finally realize what was going on with me, because I thought I was just going crazy. Let people know if you think that it's PTSD or something going on. Communicate with them. There are usually peer support groups that can help out. There's, if you're working in an ambulance service, most ambulance services have like peer support officers of some sort, or a staff psychologist, or there's some sort of entry system into helping out. Talk to those people and say, maybe we could call somebody. Maybe it would be a good idea to get a bit of time so that you're protected and you've got somebody helping you. Like introduce it that way. Do you want me to help do that? I can call somebody if you'd like. Remember, it's up to them. It's up to them to set the pace of how fast they jump into the hot bath or how slow. And if you see things going on that are inappropriate in terms of caring for people that are hurt, then speak up. Those people, if you see this happening with others, are our patients as well. And we have a right and we have a responsibility to advocate for them. So if you see some supervisor treating them poorly, or another paramedic, or somebody not working well with those people, then step in to protect them. If you have peer support officers in your service, most of whom are great and doing a good job, then praise them. But if you have peer support officers who are not working out, who are detrimental to people, then raise the alarm. Address that, because you may be the person that needs them, and the people that you care about, your partners and your peers and your friends, need them too. If you've got a bad staff psychologist or whatever, then it's up to you. And it's really important that you don't enable inadequate or inappropriate care. You need to be an advocate for the healing, helping system to work properly. And that's one of the things that you can do when you're feeling well and not under a whole bunch of stress. You can take on that challenge of saying, that is a problem that we need to fix. And I got the resources emotionally right now to challenge that. And hopefully everybody says, not okay. And if you got a lot of people saying that, you can fix the system. So that's how we can recognize problems in ourselves. That's how we can help other people that we see might be going through a lot of stress. Again, respecting their right to make a call of how fast or slow they go with this. What about getting professional help for you or for others? Well, in general, we treat stress disorders in one of two ways, either through psychotherapy, verbal usually, also some eye movement, which we'll talk about, but primarily verbal talk therapy, or medication, or, not infrequently, a little bit of both. Sometimes people who have or appear to have stress disorders might actually be having a physical disease. So there's a bunch of things that I'm still thinking we should make up a protocol for this. But there are things like vitamin B12 deficiency, or hyperthyroidism, or hypoaldosteronism, or pheochromocytoma, or physical diseases that can create within us a sense of emotional dis-ease or distress, which we could easily mistake for a stress disorder. So if you are experiencing what you think might be ASD or PTSD, it's a good idea to go to a GP and say, this is what's going on, and I'd like to just, rule out that there might be some underlying physical cause for this, as opposed to it being purely psychological. Of course, it could be both. But it's good to make sure that you're not dealing with, some sort of deficiency or overabundance of some endocrine hormone or something. And any coexisting psychological conditions need to be identified, sort of teased out and brought in. Maybe you had like long-term depression before this came in, or maybe you've got a bit of an anxiety disorder which has helped stress in, or maybe you've got a substance abuse disorder, or some sort of dissociative disorder or something. So it's a good idea to work with professionals to help tease out, are there any underlying physical problems that may have contributed to this? Are there any underlying psychological problems that may have contributed to this? And let's make sure we address those at the same time, okay? So the physical analogy is, you got a patient who's short of breath, but you got to make sure that they're not having a heart attack that's causing them to be short of breath. If you're just treating respiratory, you're ignoring the underlying cardiac that's causing that. So what are some of the treatment options? We've talked about psychotherapy. The psychotherapies that tend to be effective are stress-oriented cognitive behavioral therapies or the mindfulness-based therapies. And mindfulness-based therapies, in general, the two big ones are mindfulness-based stress reduction, MBSR. And MBSR is actually a 9-week course that you can take not as a psychotherapy, but as like a resiliency training type of thing. So that's MBSR. The other one tends to be acceptance and commitment therapy, or ACT, or it's often just abbreviated and we talk about ACT therapy, ACT. So those are particular modalities that we can get into. There's drug therapy that we can get into, usually to blunt the short-term sympathetic effects. Also sometimes to help us sleep. They'll prescribe beta blockers, but we'll get into that. And there's another therapy which I like to use as an example of something that seems just remarkably improbable, and that's EMDR. And EMDR is this, well, I think we talk about it in a second, so I'll get into it there. So first of all, the talk therapy, it helps us to integrate what's happened into our general awareness. CBT is pretty effective. If you're doing it incorrectly, that can be a problem, and we'll talk about critical incident stress debriefing, CISD, which is something that we used to do in emergency services, which we no longer do, which we'll talk about in a second. There's also something called trauma-focused cognitive behavioral therapy, or TFCBT, which is really good and really effective. And if you discover or realize, as someone points out to you, that you're suffering from post-traumatic stress disorder, it's probably a pretty good idea to find somebody who specializes particularly in this sort of work, if you can. There are few people out there, and we're getting more and more, who were cops, paramedics, firefighters, and they've become counselors who have started to work with people who are, emergency services personnel and are able to help out. And there's a real face validity to those people, because if you walk in, I had clients come in and say, what do you know about this? And I say, look, I was an inner city medic for 14 years and I had post-traumatic stress. I worked as a critical care paramedic, and now I've got my master's in counseling psychology. And just instantly it's like, okay, all right, you've been there. And if that's necessary for you, that's great. It's a good thing to do. Having said that, they don't necessarily have to have been an emergency services personnel in order to understand this. There are people who counsel alcoholics who were never alcoholics themselves. There are people who counsel people with depression who have never been depressed, and they're very effective and they're very good at it. So it's not something that is required, but if it's useful for you, then check it out. But I would say, don't just grab a general counselor. Try to find somebody who specializes in acute stress disorder and post-traumatic stress disorder, because it's a bit of a specialized field. So, CISD, you may have heard about this. Back in the early 1980s, a guy named Jeffrey Mitchell came up with critical incident stress debriefing. It caught on like wildfire in the fire department and the emergency services in general, and everybody started doing it. It was something that became almost mandatory after, in some cases was mandatory after critical incidents. They'd say, you're off the road, you have to go do a critical incident stress debrief, because that's supposed to be good for you. And what we found, through no ill intentions, this isn't Andrew Wakefield or anything like that, but what we found is that it has actually been shown not to help, and it's possibly harmful. So we no longer do it. And there's a good article I've put a link to there by, I think it was Brian Bledsoe who did that article. Really great article summarizing how we've changed our thinking about critical incident stress management and critical incident stress debriefing. And one of the unhealthy aspects that was in CISD that still pervades our culture is this belief that you should force people to talk about it so that they can cathart and get all this emotion out, even if you have to pull it out of them, and then they'll feel better. And what we found is that forcing people to re-experience things that they're not yet ready to re-experience is re-traumatizing, and it exacerbates the original problem. So that's why I've been stressing, don't do this, because that culture still exists in our, or that idea still exists in our culture. Don't buy into it. Drug therapy, selective serotonin reuptake inhibitors are usually the drugs of choice for this. So Zoloft, Paxil are approved, at least in the United States, for the treatment of PTSD. We also use beta blockers, which blunt off the sympathetic nervous system, so it's difficult for us to get into this hyperarousal, and propranolol could be one of the beta blockers often that are prescribed to blunt the sympathetic response. You can use benzodiazepines like Valium, but they've found not to be helpful over the long term, so they're useful for the acute exacerbations. That's why I said if you're having trouble sleeping, talking to your general practitioner about like temazepam or something like that, a short-acting benzodiazepine. But it's not something you do for more than like about a week or so, because we tend to habituate to benzodiazepines and they lose their effectiveness. And as I said, beta blockers. There's this other bizarre thing, and I say bizarre with all respect because when I first heard it, I honestly thought, and a lot of people thought, what a load of crap. It's called eye movement desensitization and reprocessing. And the basic idea is this. You put your finger in front of the patient and you ask them to recall some of the stressful incidents that happened, and while they're doing it, you move your finger in a particular pattern and you have them follow your finger, and that's supposed to help. And when we first heard about this, I remember when EMDR came out, we were all like, that's just ridiculous. How can anybody think that it actually happens? Well, guess what? It actually happens, and it actually works, and it's been shown to be really quite helpful. So if you go to somebody and they start doing this, or they start tapping you as you're, telling the story, and you think, what sort of weird, bizarre thing is this? It's actually an effective treatment that seems totally counterintuitive, but actually really works. And some people are very comfortable with it. And a lot of counselors who've been doing trauma counseling for a long time have been amazed once they start using EMDR of just how effective it actually is. They say that the progress that their patients go through is much more rapid than what they're used to seeing in their patients. So I want you to be aware that EMDR is out there, and that it is an effective therapy, even though it seems kind of like a quack treatment, it isn't. And don't deny yourself the help that EMDR can give you just because it seems odd on face value. So how long does this last? Well, it depends. No matter how long it actually lasts in terms of quantifiable time, I can tell you experiencing it is interminable. It just seems to go forever and ever, and it's very depressing. But how long it actually objectively lasts, a lot of it depends on the individual patient, the comorbidity, the resiliency that already exists in them, and a whole bunch of factors that we haven't even quantified yet. So there's no clear answer. And if you ask your counselor, how long does this last? And they give you, it's going to be 17.3 months or something like that, and they really don't know what they're talking about. So make it easier on yourself and your counselor. And a few months into it, you can say, how does it seem to be going? But anybody who tells you exactly how long it's going to last is feeding you false promises. Usually-ish 36 months if a patient is getting treated as an average, but there's a wide variety. Like the bell curve is pretty wide on that. So probably, more than a year, more than two. It takes a while, but it won't be constant thing, you're better. There's a gradual, abeyance of symptoms with treatment. So the initial terror that you're feeling when it first starts, that doesn't last forever. If there's no treatment, then longer, about twice as long, really, in people who don't get treated. But the sad news is, unfortunately, a little over a third of people who get PTSD will never actually functionally recover. That's a lot. That's a lot. If you know 9 paramedics who got PTSD, which isn't unlikely, then 3 or 4 will never actually recover. They'll never actually come back to the job. They may never be able to work again. That's a pretty high morbidity in a disease. So it's a serious condition. And it's those people often who are the ones who say, well, I don't want to keep on going. For those of you listening who are in Para 104, be aware that our university and other universities as well, if you're a paramedic student, will almost invariably, we do, I know other universities do as well, have free, confidential, non-denominational counselors who are there to help. They do not communicate with the lecturers. If one of my students goes to see a counselor, I never hear about it. Those two are kept separate. It would be unethical for the counselor to even talk about me. So, or talk to me. They can talk about me. So if you go in and you're worried, if I talk to them, is that going to affect my progress in this degree? It absolutely will not. We won't even know that you're doing it. We won't even want to know that you're doing it. That is up to you, and it's a healthy thing to do. And it's really important that we maintain that safe space so that you know that it's safe for you to be able to go there. And if you don't want to see a university counselor, if it still feels a bit too close to home, they can make referral to other counselors as well. If you're a paramedic working out on the road, then there are employee assistance plans that you can take a look into. And if you don't want to, if you feel there's a bit of a conflict of interest, then you can go get help on yourself, autonomously, apart from where you're working, and just keep it separate from your employer so that it doesn't affect your work relationship. And unfortunately, in this day and age, I would say that that's probably not such a bad idea. I know a lot of people who have, availed themselves of help at work and let people at work know that they're suffering, and eventually they were really kind of punished for it. Our culture still sometimes has that in there. I don't say that to be judgmental of other people, but my priority in this is talking to you as the person who might be affected by critical incident stress. And I think I'd be remiss if I said to you, don't worry, it's perfectly safe. I don't know the conditions of where you work or what you do. And that really is a judgment call that you need to make. And I, and any other, I think, reasonable person would not criticize you for saying, I just don't want my employer to know about this. That's not such a bad idea. So if you have any questions, as normal, feel free to post them in the YouTube comments. You know what I really enjoy? I really enjoy it when people tell me where they're from. So I've had people on other lectures say, hey, I'm listening in from Ireland or I'm listening in from the United States. And that's really kind of cool. I like hearing that. So even if you just want to say, interesting, thanks, I watched this from Israel, I watched this from Australia, I watched this from South America, wherever, let me know. I kind of like hearing that. And if you have any particular questions, I'm happy to help. I have to say, I can't do counseling. I can't do it over YouTube. If there's something that is really emotionally pressing for you, then you're going to have to deal with that outside the confines of this type of an interaction. But if you're curious about the course content material or curious about something generally, or if you want to ask and say, I have a friend who, I can get into that a little bit. Again, thanks for listening. I hope you enjoyed it. Hope it's really helpful for you. Take care.